first thing we'll be looking at is stigmata of chronic liver disease. Stigmata. Yes.
It's not alcoholic steatohepatitis in the same as non-alcoholic fatty liver.
Yes. Because this is here. That's why we also call NAFL, Alright, let's move on. And next we'll be looking at stigmata of chronic liver disease. When we say stigmata, remember stigmatization. Peculiar. Something peculiar to you. Okay, that's why stigmatization of coronavirus patients should be what? Reduced. There should be education on the viral infection to reduce stigmatization. Wow. So when you say stigmatization, there's something like a scene that is making you know that okay, this person is having this and that. For HIV, if you look at HIV stage 4, if you refer to HIV wasting syndrome, okay, wasting syndrome. From stage 3 going, there will be HIV wasting syndrome, where they will lose more than 10% of their estimated normal weight. Then when you see some patients say, hey, this person is having HIV, you don't know how it is. You say, this person has no sweet hope. If you is having HIV, right? Yeah. So that becomes what? The stigma. The stigmata. We are looking at those peculiar characteristics, okay, of a particular condition. Okay. Now let's look at the stigmata of chronic liver disease. The first one. So what we are going to do is that to easily remember, just take it from the head all the way down. Okay, from the head. We are going to look at the head. What are we going to see on the head? Then we'll come to the front. Okay. After we finish the front, then we'll go to the hands. Okay. Okay, let's do that. So on the face, the first thing, pallor. Pallor, normally if you examine a patient and you check the conjunctiva, and it's almost without white, so it's not red as supposed to. If the redness is decreasing, inside that is becoming white, then you can grade the patient on what you are seeing. Either is what paleness of 1+, 2+, or 3+, which are noting what anemia. Are we getting that? So yes. Why are we saying why were patients pale in the first place? When they're chronic liver disease, yes, what? Yes, correct.
Oxidative stress radicals would cause red blood cells to be increased.
Yes, that's one way. Yes, another way.
The liver stores iron and ferritin. So with the damage of the liver, there's poor erythropoiesis due to the insufficient iron in the liver.
That is true. So we can take it from two aspects. Okay. What she said and what you also said. So the first one is that what's the main function of the liver? Yes, detoxification of what? Harmful substances into and harmful substances. So if the liver function is impaired, then it means that these toxic substances will become available in circulation. So we are going to have free radicals or oxygen species creating high oxidative stress for the red blood cells, causing them to hemolyze. And if they hemolyze, they are going to have what? Hemoglobin, which will go into the bilirubin synthesis pathway. Even, I mean, it means that we are getting to know this. But if you are having red blood cells hemolyzing, okay, like that, then the AG level will drop. And to backtrace that point, we could also add that the liver stores what? Iron in the form of ferritin. So that in the case of what? Erythropoiesis, the iron will be made available for that process to happen. But here like the case, the liver is what? Damaged. It's unable to what? Provide the iron needed for erythropoiesis. So at the end of the day, we are going to have decreased synthesis of what? Red blood cell erythrocyte. giving rise to what? Anemia. So in that pathway, we will have jaundice immediately, which we already explained. Jaundice. Okay. Another stigma that we can also realize is will be a parotid gland enlargement. Okay. This one you see mostly in alcoholics. It's more common in alcoholics because of the irritative or inflammatory cascade inductive effect that alcohol will have. Okay. So it causes the parotid gland to become inflamed. And if it's inflamed, one of the cardinal features of inflammation is what? Tumor, which is swelling. Have you heard that? So when you see the parotid gland, once it's enlarged, it becomes what? Swollen. Have you heard that? The swelling making it enlarge. Have you heard that? All right. The next one, from there, we can count down. Have you heard that? So there are some of the list. Another thing that you should also remember is that the liver is also involved in what? The lipid metabolism. True of course. True. Lipid was synthesis. Lipid metabolism. So if the liver is deranged, then what are we going to have? We are going to have circulating lipids. And some may deposit in the islets. If it's deposited in the islet, how do you call that? Yes, get it. Santelasma. So santelasma, simply put, is what? Xanthoma of the eyelid. Is that clear? What then is xanthomata? We spoke about this before. Yes, anyone? Xanthomata. Yes, go ahead.
It's localized part of the system under the skin, over the tendons, and stuff.
That is correct. So localized deposit of fat. Okay. Under the skin, over joints, tendons, hands. That's what I said. Hands and your feet. That's correct. So we made mention of the last one, that's xanthoma of the eyelids. Okay. And we said that xanthelasma can be normal in people of age greater than what? 60 years. Right? But if you are less than that, then you are having xanthelasma, we will consider it as well, pathological sign. Is that clear? Yes. Then we'll come to the trunk. The trunk, we can look for gynecomastia. We say that gynecomastia is the most common cause of breast swelling in males. How do you know that? When it comes to males, with the male breast swell, the most common cause of that will be what? Gynecomastia. And again, what accounts for gynecomastia in chronic liver disease? Anyone? What accounts for gynecomastia in chronic liver disease? Yes, right. Which will
also the proliferation of breast tissue.
yes, leading to gynecomastia. So what you have to know is that we have something we call the sex binding. We call it sex hormone binding globulin. Okay, sex hormone binding globulin. Sex hormone binding globulin. Okay, what the sex hormone binding globulin does is that it tends to regulate the levels of estrogen and testosterone in circulation. Anytime testosterone or estrogen binds to the sex hormone binding globulin, it renders them inactive. It means that they become inactivated. They are not able to function, they will not have any effects any longer. Are we getting that? So sex hormone binding globulin is more of a regulator, and it is produced from where? It's produced by the liver. So in a case where there is what? Liver cirrhosis or chronic liver disease, what is going to happen? The levels of sex hormone binding globulin will reduce because there will be decreased production of the sex hormone binding globulin. Are we getting that? Are we getting that? Giving rise to what? Essex free circulating estrogen, okay, which causes the over-proliferation of the breast tissue in what? Men, leading to gynecomastia. Exactly. It's really understand. Okay, so in that same vein, let's say the sex hormone binding globulin is there. If we take estrogen and testosterone, which of them has a greater affinity to sex hormone binding globulin? N7. But if you should go a bit deeper, you take DHT, that's dihydrotestosterone, and testosterone. Which of them would have a greater affinity? As what? As what? No. Yes, dihydro. The active form of testosterone is dihydrotestosterone. So dihydrotestosterone will have a greater affinity for sex hormone binding globulin than the testosterone itself. Are we getting that? Is that clear? So that is the reason for gynecomastia and chronic liver disease. And gynecomastia includes the males, not the females. Is that clear? The next one, we'll talk about spider navy, or what we call spider angiomata. Okay, this is how it's going to look like. We've all seen a spider before, right? This is looking like a spider. Spider navy. Spider angiomata. So the spider navy or the spider angiomata consists of what? A central arteriole. So this is the central arteriole. Consists of a central arteriole from which other vessels emanate. From which other vessels emanate. Okay, from which other vessels emanate. It consists of a central arteriole from which other vessels emanate. Are we getting that? If we take the spider navy, on clinical examination, it blanches. It will blanch. Okay? It blanches with what? Pressure. Do you know why? Because if you press your hand here, it's like the fluid is there. Okay? When you press your hand, you are trying to eject the blood from the central location. Okay? So the whole area becomes white. And when you remove the pressure, the blood flows in back. Okay? How do you guys do that? So it blanches the pressure. And you should also know that for spider navy or angiomata, it fills from the center. So it means that all the small vessels taking their origin from it is going to flow in that direction. It flows from the center. From the center towards the periphery. So it flows from where? The center. Are you getting that? Are you following? And also another thing you should know about spider navy or angiomata is that it is found in the upper part of the body, which is drained by the superior vena cava. We go to the upper portion of the body, which is drained by the superior vena cava. And in the chronic liver disease patients, okay, you may see spider navy. Exactly. So the upper portion of the body, upper body, drained by what? The superior vena cava. Exactly. When can we say that what we are seeing is spider navy angiomata and not something else? You will only say that it's a spider navy, okay, if we have more than 5 of them. If you have more than 5 of these, then we'll say that it's what? Spider navy. Are we getting that? But if you have less than or equal to 5, we'll say that it is not spider navy. Are you getting that? You should bear in mind that patients, females, who are taking oral contraceptive pills can also develop what? Spinal nail. Are you following? Are you following? So unless you are seeing a number of greater than 5, then you can say that what you are seeing is spinal nail. But if it's less than 5, you don't say that it's spinal nail. Please, is that clear to you? Alright, let's move on. Yes.
Do you mean the vessels emanating from the central vessel or the number of the whole?
Yeah, the whole structure. The whole structure. The whole structure. If you have more than 5, if you have it here, let's say you have it. You have one, as this you have another one. You have another one. You have another one. Okay. All in the upper portion of the body, then we can say that's spinal nail. Yes.
Is that also caused by the increased estrogen?
Increase.
Increased estrogen?
Yes, it's called, that's why I told you that those that are taking oral contraceptive pills can also develop that because of what? The increased circulatory what? Estrogen. Okay? Increased level of what? Circulatory estrogen. They will give rise to. Okay? Let's move on. The next one, if you look in the pubic areas and what? The axillary areas, pubic and axillary, yes.
So with the 5, more than 5, that one is much specific to liver disease.
Yes.
And less than 5 is to other conditions.
Yes, other conditions. When it comes to chronic liver disease, more than 5, then you are going towards what chronic liver disease. You could have less than 5, but it has not fallen to this particular condition. Okay. All right. So the next one, we will say that loss of pubic and axillary hairs. Okay. Loss of pubic and axillary hairs. Loss of pubic and axillary hairs. We can also think of, again, another thing that's here is, in this case, because of the high level of estrogen in circulation, the testes will start to undergo atrophy because it's not finding its stimulator, the testosterone is not there. Are we getting that? So the testes will undergo what we call atrophy. They will have testes, there will be what? Testes atrophy. Testes atrophy. Testes atrophy. Testes atrophy. Testis atrophy. Testis atrophy. Another thing that we will also look at is what? When it comes to the farm, when you look at the abdomen, it becomes distended, so they would have ascites. Okay? Ascites. How will you clinically elicit ascites from physical examination?
Shifting the lungs.
You will not want to start from there. When you are doing physical examination, you start from inspection, okay? You come to what?
Location, auscultation.
Auscultation. But when you are doing abdominal examination, it will not follow that path. Which path will they follow? Inspection, auscultation, palpation, and ventilation, yes. Do you know why? Why?
Because if you do the palpation or the auscultation, it can affect sound, or sound.
Yes, it will stimulate. Yes, it will what? Stimulate what? Sounds, okay, which were originally not there. But when you do palpation, definitely you will be touching the valve. Deep palpation. When you touch the valve, it becomes stimulated, and there will be what? Increased peristaltic action or activity, which will generate what? Lesser sounds, which you will hear, say that okay, this is like that, but it's all right. Okay.
Please, I gave this order to a doctor at the hospital when he disagreed.
So what did you say?
He said they should still follow the.
No, because you see, when you are talking about abdominal examination, it cannot follow. It's not the standard because I mean that's the standard that is there. so that you don't have false positives.
So these are the exams should
Yeah, that is the standard. I mean, everywhere you go, that is the standard. I think that's good. That's the standard. All right, let's go back. Let's go. So, on inspection, so for the scientists, how do you use it? On inspection, what are you going to see? You have distended abdomen with fullness at the site. Okay? Find it. I mean, how will you use it? What will you find it? Okay? So in that case, patient should be lying supine. Okay? You see a distended abdomen with fullness at the sides. With fullness at the flanks. Fullness at the flanks. Distended abdomen with fullness at the flanks. That's at the side. The next thing that you will see on inspection will be everted umbilicus. There will be everted umbilicus. Everted umbilicus with a transverse slit. If you watch your umbilicus, you realize that it is facing down. And remember, when we're talking about ECG, this is a normal pattern. P, Q, R, X, T. If you have the T like this, and along the way, it changes to become like this, then we'll say that the T wave has undergone an inversion. Therefore, it's an inverted T wave. So this is how your umbilicus is supposed to be normally. But the moment it becomes like this, then we'll say that what? It is what? Everted. Exactly. Have you getting it? Are you following? Everted, it means elevation. Inverted means that you are going down. Are you getting that? Are you getting that? So this is what we are describing as what? An everted umbilicus with what? A transverse slit. Exactly. The transverse slit means that if you take the umbilicus, there's going to be what? A depression at the middle portion of it. Are you getting that? As if it's a coffee bean inside, but it's not. Are you getting that? Okay. Then, again, on inspection, if you take, let's take this as the sternum. If you take the sternum, you know that this is a manubrium. This is the corpus of the sternum or the body, and this is a xiphoid process, or what we call a xiphoid sternum. We'll take this as our umbilicus, and we'll take this as the pubic symphysis. Okay? Should we measure the distance between the xiphoid sternum and the umbilicus? This distance, and compare it to the distance from the umbilicus to the pubic symphysis, you realize that there's going to be variation. This distance will be greater than what this distance. Are we getting that? Are we following? So again, that will still be on inspection because you are measuring and you are seeing. So again, on inspection, the distance between the xiphoid sternum and the umbilicus, the distance between the xiphoid sternum and the umbilicus is greater than the distance between the umbilicus and the pubic symphysis. The distance between the xiphoid sternum and the umbilicus is greater than what? The distance between the umbilicus and the pubic symphysis. Yes.
So because it's being regular and normally it's supposed to be the same.
Almost the same. Do you know why? If you look at this, okay. So let's take this as our landmarks. Xiphoid sternum, umbilicus, pubic symphysis. Okay, almost the same. But now look at what is going to happen. If this become like this, okay, this is going to stretch forward, and it's going to push this one closer to what? So the xiphoid sternum is going to be distant. It will be further distant from where the umbilicus, because this is stretching forward, and the umbilicus will be brought towards. It will be brought nearer to the pubic symphysis. Are you getting that? So if you check this measurement and this one, you realize that this becomes greater than this. Why? Because the ascites is causing the umbilicus to move forward. Yes.
So based on this finding alone, you can't say that it's ascites because people with distended abdomen.
Yes. So it's not only one finding that we are moving. Okay, it's not just one finding. Okay, all right. Now that's for the inspection. Now the next one is vacation. Because the palpation, there's nothing like that. Going to find over there. I think that unless you want to find an underlying condition, for example, tumors, malignancies can cause cystitis. For example, if you take ovarian fibroma, it will give you a syndrome we call Meg syndrome. If you take fibroids, uterine fibroids, it will give you a syndrome, ascites, and what? Right-sided pleural effusion. How do you know that? Meg syndrome. That's correct. So you realize that there are other things that could give you ascites. So if you are palpating, you want to find a mass in that movement. That is not what we are looking at. Okay, ascites as well. Okay, so in this case, the next one will be what we are doing, vacation. Okay, vacation. We have to demonstrate that. So we are going to make some assumptions because we don't have an examining table. Okay, so this is our supposed the result of the patient. An example actually we are assuming that is our assessment for examination. Now he's lying down to fine. Lying down to fine. So what we are going to do is to start the cursing. Okay. So you can move from where? The light post all the way to the right iliac or closer. So you start percussing, okay, 1, 2. So let's assume that when I reach this point, there was a dull percussion note there, dull percussion sound. What will I do? I'll leave my finger here. What I'm using to percuss, how do you call that? Flexor. And with my hands that are fixed here, the fleximeter, that's correct. So once I've done that, what I'll do next is I'll ask him to turn onto his left lateral side. So it means that he will now turn onto the left lateral side. So let's say, so this is the left lateral side, okay? He's lying on the left lateral side. First he was lying supine when I got the point of dullness, okay? Now, when I got that point, I left my fleximeter here and I asked him to turn onto the left lateral side, okay? Once he did that, what do? I'll start percussing towards the left lateral side. Okay, so I'll start going in that manner to the left lateral side. When I start percussing from here, the sound will change from down to tympanic. Why? Because the fluid in the peritoneal cavity has moved or shifted to where he is lying on the left lateral side. So until I get to that side, I may not hear a dullness. Okay, if it's ascites. So once I'm moving, I realize that when I reach here was the panic, but now a new side forward, dullness has been seen or heard. So in that case, I'll say that there was dullness here, but when I asked him to move onto the left lateral side, it has shifted to that direction. That is what we call shifting dullness. Do you understand? Thank you very much. So that's what we call shifting dullness. Okay? Please, you get the demonstration. Okay, that's what we call shifting dullness. And shifting dullness, you can edit it in ascites. Okay? So shifting dullness, that's what I demonstrated. On percussion, you have a shifting dullness. Shifting dullness. Then the last one, we call it fluid trail. Fluid trail, you can only elicit it in massive ascites. When do we say there is massive ascites? Yes, anyone? Yes. There's more than 1 liter of fluid where? In the what? Yes, in the peritoneal cavity. Okay. Yes, are you getting that? Yes. More than 1 liter or 1,000 mils. Again, how do you elicit that? 1,000. Yeah, I'm going to study it. So how do you elicit a fluid trail? So for the fluid trail, patient lies supine. What you are going to do, you are going to fix your left hand here on the left line. Okay, on the left line. Okay, on the left line here. What are you going to do? Then percuss the other side. Okay. Okay, this hand is fixed here on that. So when you percuss, okay, you expect waves Okay? Because when you heat, the fluid that is closer to where you are heating is having potential energy. The moment you heat it, you will cause the molecules to collide, where they will start exhibiting what? Kinetic energy. So they will start moving away from the source of what? Higher pressure, which you generated, to the side of what? Lower pressure. So as they move, they hit each other, generating waves. And these waves will be transmitted through the fluid to the other side, the wall, that side. So in that case, you are going to what? Feel thrills in your palms. Okay? And thrills are like transmitted noise. Okay? So when you hit, the waves will move from the right to the left, hitting your body. If only the fluid quantity in the peritoneal cavity is more than 1 liter. This are we getting at? If it's more than 1 liter, then that's what we are telling us what? Massive ascites. So fluid thrill is only positive in what? Massive ascites. If it's not massive ascites, it may not be what? NCD. Please we hear that. So that's what we call fluid thrill in massive ascites. Is that clear? Is that clear to you? Let's get started. Let's move on. Then the next one, caput medusa. Caput medusae. What is the caput medusae? It refers to what? Refers to enlarged periumbilical superficial veins. Enlarged periumbilical superficial veins. Enlarged periumbilical superficial veins. And what will account for that? Anyone? What will account for that? Excellent. So that will be what? Portal hypertension. That's correct. Portal hypertension. It's resulting from portal systemic shunt. And the portal systemic shunt will happen when the portal pressures exceed 10 millimeters of mercury. And you should know that the normal portal pressures range from 5 to 10 millimeters. Is that clear? Okay. And mostly these ascites, caput medusae, they will start coming in when liver disease is becoming complicated in a way where portal hypertension is developing, because ascites result from portal hypertension, caput medusae from portal hypertension. Are we following? Yeah. All right. The next one in the abdomen, splenomegaly. Also coming from where? Hypertension, that's correct. Then we can also talk about hepatomegaly as well. The liver becomes what? Enlarged in the initial state. Hepatomegaly progresses to a small liver. Okay? So initially, compensatory phase it will enlarge, and as it reaching in the decompensatory state, it will start shrinking. Because fibrous tissues are being deposited, breaking fibrosis is closing, is pulling the cells together, and the size of the liver decreases. Is that clear? Now, let's move to, once we are done with the tongue, let's go to what? The hands. The hands. When you go to the hands, we can look at the nails. Remember when we were talking about flapping? One of the gastrointestinal causes of flapping, it was what? We mentioned chronic liver disease or liver cirrhosis, right? So yes, flapping of nails. Flapping of nails. Usually, what is the test stage of flapping? What constitutes the test stage of flapping?
The test stage is when there is an increase of to the movement.
Increase?
Pleasures between the body.
That's what, yes, like that.
The angle between the nails and
Yes, to
increase convexity of the nails.
increase convexity of the nail. What does that mean? And the increase convexity of the nail in both transverse and longitudinal direction. And the fifth stage, hypertrophic osteoarthritis. And we said, if you look at that, we could have that in some conditions. One of the conditions you mentioned was what? The mammary here parental syndrome. Here is also known as pachydermoperiostosis. Okay. Alright, let's move on. Clubbing of nails. The next one, regarding the nails, we have what we call lecomedia. Lecomedia. Please, you can download the picture and put it on the page as usual. Lecomedia. If we talk about lecomedia, you will realize that the whole finger then will become very white, become white, paper white. And if you look at your nails, getting towards your nail follicle, you see, if you look at your nail, okay, let's say this is our nail, okay. If you are getting towards the nail fold, you will see some demarcation like this. Some of you have this. It's more white, okay. This is what we call lunuli. We call this lunuli, okay. Lunuli, okay, lunuli. We call it lunuli, okay. So in lecomedia, leco means white, okay. Lecomedia refers to what? The whitest discoloration of the nail with undemarcated lunula, meaning that we are not going to see the lunula again. It will become blurred white. It will become colored. It will be colored white as well. Is that clear? Is that clear to you? Whitest discoloration of the nail with undemarcated lunula. I hope you have seen the picture. Have you seen the picture? Whitest discoloration of the nail with undemarcated lunula due to hypoalbuminemia. Meaning that the level of albumin has a decrease. Okay, if the level of albumin decreases, then what happens? The coloration of the nail also becomes impaired. Meaning that in that case, you turn and you pick a white color. Okay. So if you have white discoloration of the nail with undemarcated lunula due to hypoalbuminemia, we call that lecomedia. Is that clear? Then the next one, we can talk about Terry's nail. Those of you watch football, John Terry. Terry's nail. So for Terry's nail, let's take this as our nail. If we divide the nail into 3 portions, okay, 3 portions. So proximal 1/3, 2/3, distal 1/3. Are you following? So this is what is going to happen. In Terry's nail, the proximal 2/3, okay, proximal 2/3 of the nail is colored white, has whitish discoloration. While the distal 1/3 has what? A reddish discoloration. And the proximal 2/3 is white because of hypoalbuminemia. The distal 1/3 is red because of what we call pele-angiomas. Are you getting that? So yes, Terry's nail is defined as well. Whitish discoloration of the proximal 2/3. Whitish discoloration of the proximal 2/3 of the nail. Proximal 2/3 of the nail due to hypoalbuminemia. Proximal discoloration, whitish discoloration of the proximal 2/3 of the nail due to hypoalbuminemia, and reddish discoloration of the distal 1/3 of the nail due to teleangioectasia. Due to teleangioectasia. Due to teleangioectasia. Okay, the teleangioectasia also it may mimic spider navy, but it's not spider navy. The teleangioectasia has no central arteriole. If you look at the teleangioectasia, it has no glange in pressure. It flows from the periphery, it does not flow from the center. Are we getting that? That's the difference between the teleangioectasia and the spider navy. Are we following? So there is no whitish discoloration of the proximal 2/3 of the nail due to hypoalbuminemia, and reddish discoloration of the distal one-third of the nail due to telangiectasia. Please, how do you know that? Then next one, we go to the palms. We have what we call the Dupuytren contracture. Dupuytren contracture. For Dupuytren contracture, yes, go ahead. What is Dupuytren contracture? Excellent. So it's defined as what? The thickening and fibrous contraction of the palmar fascia. Thickening and fibrous contraction of the palmar fascia. Thickening and what? Fibrous contraction of the palmar fascia is known as what? Dupuytren contracture. Is that clear? You can get the picture and put on the page as well. Dupuytren contracture. Dupuytren. So it means that the hand will become curled like this. You are not able to extend it because the palmar fascia has become what? Shortened and thickened. It's thickened and what? It's contracted. It has become what? Contracted and it's thickened. So your hand will become like that. It's not able to extend. That's what we call Dupuytren contracture. Good. With the brilliant definition that you give, what's another name for Dupuytren contracture? From the definition that you give, it's also known as what? Palmar fibromatosis. Palmar fibromatosis. Palmar fibromatosis. Palmar fibromatosis. Okay. Then the last one will be palmar erythema. Palmar erythema. Palmar erythema. Yes, what will account for the palmar erythema? Yes. Excellent. Which causes what? Vasodilation in the what? The palmar vessels, increasing blood flow toward the palms, giving the reddish discoloration of what the palm. That's what we call palmar erythema. So the hand will become red. I mean, it's like that. It's due to what? Increased circulating what? Estrogen. That's correct. This is like that. Okay, let's move to the investigations. Yes.